Right, so the talk today is because it's basically, I think it's International Sepsis Day. So I'm going to basically talk about what you guys use on the ward in terms of identifying sepsis on the floor. So if I can ask the nurses on med-surg, what do you guys use on the floor in terms of identifying sepsis? Does anybody know what the signs of sepsis are? Or, and I'm not talking when they're clapped out, mottled, and what are like sort of what do you use any algorithm on the floor?
Yeah, we have a screening
protocol.
So what's your screening tool?
It's if they're tacky, if they have a temp, if their respirate's up, if their white blood cells jump, if they have a high sugar and they're not necessarily a diabetic.
Okay, and what do you have to score to be able to trigger it? Just one of them?
You have to have two and then you move to the next step.
Okay. So if we can start off, does anyone know about quick SOFA?
No.
So that basically looks at blood pressure. So it's a bedside test. It's a bedside. You look at mentation, you look at the rest rate, and you look at the blood pressure. So if the rest rate is above 22, if they have altered mentation, or if their systolic blood pressure is less than I would say less than 100, then if you have two out of those three, that triggers that it's sepsis, basically, and that's pretty good. There are several other cumbersome algorithms that you can use to try and identify sepsis. So if we look at clinically, what are the clinical signs of sepsis in terms of clinical findings? What do you guys look for?
Like accessory muscle use with the respiration?
So we can look at observations first, and we've talked about respiratory rate greater than 22, and we talked about blood pressure. But what about temperature? What do you guys use as the ranges for temperature?
38.3? Is it over 38?
Over 38.6 you draw cultures.
Yeah.
38.
Okay.
But it could be under though too.
And what's the
Yeah.
bottom? What's the bottom one?
36.
36.
Yeah, less than 36. So which population group in terms of fever is highly unreliable?
Older adults.
Immunosuppressed?
Immunosuppressed, older adults like the elderly. What else? Just remember with iatrogenic what we're doing. So if we're giving them Tylenols for pain or non-steroidals for any other reason, that's going to mask a temperature spike. Okay, so but remember the one that I want you to do is the low temperature, the hypothermia. Okay, well, less than 36, particularly in the elderly. Okay, what about your heart rate? What do you think?
Over 100?
Okay, tachycardia. Yeah, and then
60?
okay, yeah. Well, I would say look, a heart rate of, if you're lying in bed,
Yeah.
and I know they say tachycardia is over 100, but if someone's lying in bed and they're batting along at 90, that's also abnormal. Okay, so you expect someone that's lying in bed at rest, now suddenly batting at 90 beats and above, lying. That I would tell you that you need to flag that. Okay, so don't use 100. Although the definition is more than 100, I think 90 in somebody that's recumbent in bed is definitely a problem. Okay. The blood pressure itself, we know about systolic blood pressures, diastolic blood pressure. What about something called the pulse pressure? Which of the two, if you see somebody that has, what's the sequence of events in somebody that goes from developing early sepsis all the way to septic shock in terms of heart rate and blood pressure? Does anyone know?
Pulse pressure?
Yeah. So they get bounding pulses and they're usually peripherally warm. But then what you'll see a tachycardia first. Be careful, because you always check with terms of tachycardia, make sure they're not on beta blockers, because that's going to mask it. Right? Tachycardia first, and then you're going to see the blood pressure, with the systolic or the diastolic starts to go low.
The diet?
That's right.
Yeah.
So you get peripheral vasodilation,
Yeah.
and your diastolic drops, and then your systolic will stay high, and you'll have a bounding kind of periphery, okay? And then and that's, you've got to try get in there before that, because the next thing that happens is the systolic will just collapse. Okay, what mean arterial pressure is necessary for perfusion of the kidneys?
75. Isn't it? 75?
60.
Oh.
60. Okay, so now that's used loosely, eh? So I would say to you, in an elderly population, you probably want it higher. You probably want it around 70 odd. For a young sort of middle-aged person, young to middle-age, 60 I would think is absolutely fine. But in our elderly group, we need to basically know, I would tell you to work with 70 generally. I mean, take each context of each patient in mind when you evaluate them. Eh? In terms of, so that's very important to try and pick up. Are there any other, so respirate, changing in either hot flushed, diaphoresis, tachycardia, and then you said your high risk group patients, which are? I want to just go through the high risk patients for sepsis.
Immunocompromised, if they have any more comorbidities.
Okay, immunocompromised, right? We've talked about that's on medications, and then we can talk then there's the immunocompromised would be HIV, diabetics.
Like if they're going through chemo.
Yeah, so immunosuppressed. Eh? So immunocompromised means we can use suppressed versus compromised.
Okay.
Compromised would be someone like a diabetic, chronic renal failure, anything that's going to interfere with the action of the HIV positive, cancer, especially your lymphoproliferative. They are immunocompromised purely by their state. Then you have suppressed, which are the ones that what we are doing to them. We're giving them steroids. We're giving them immunosuppressants. And things like that. They are the two groups that will basically cause, so those are your high risk groups. What is currently occurring on the floor now when you trigger the septic protocol? So say somebody, this is what I'm interested to find out. So if you trigger the septic protocol on the floor, what do you guys do?
Well, we would have gone through the little ticky box, and then we call the doctor, I think. I think that's what it is.
And how long does that whole process take?
Maybe 5 minutes.
5 minutes, same.
Yeah, easy. Just one assessment, and then.
One assessment, you get caught, and then they come in, and then they do blood cultures if it's high enough, and then a lactate, and then antibiotics are given usually, or?
I think that's up to the physician, like what we would be giving. I think
It's not on the
it's
sheet.
not on the protocol.
No, on the protocol. Okay.
Yeah.
Okay. So the take-home message for sepsis is that I want the nurses to be very aware of the confounders, especially because sepsis and the successful treatment of sepsis is done on the basis of early identification and early instituting antibiotic therapy, appropriate antibiotic therapy. The other groups that are at risk are anybody that's been in hospital or has been in hospital in the last 90 days. So a readmission, high risk for sepsis. Okay, so I want you to probably make sure that you put that patient into the same categories as the ones that we've mentioned before. So any patient that's been in hospital in the last 90 days that has a readmission, you need to flag them for a possible sepsis.
Well,
Okay.
I'm curious why would they be more?
So the thinking being, so this is just epidemiological studies which they've done in hospital where they've actually looked at who gets sepsis, and they found that these people that are readmitted within the last 30 days definitely are at higher risk. The reason being is prior antibiotic use, so they think that there's a change in the whole microbiome of their body. Secondly is the colonization of those people with hospital-acquired, and the fact that they have other comorbidities that are possibly. But if you see that in a patient, be very quick to have them. They should be flagged. So they should have a septic flag to say, listen, if this guy so much, or this lady or patient so much as farts the wrong way, we're going to have a look a little closer for sepsis.
So what's the anticipated antibiotic treatment? Because if we're waiting for someone to make a protocol decision, we could maybe anticipate by getting some antibiotics,
Yeah, so I would tell you that if they've been in hospital, so it's very different. So sepsis on the floor versus sepsis in emerge. The floor, if they've been in hospital for longer than 48 hours, they need piptazo. It should be considered hospital acquired until proven otherwise. Okay, so if they're penicillins, if they're not penicillin allergic, I mean piptazo, a renal adjusted dose straight off the bat is the way, after blood cultures, is the way forward. Okay. I also want to, I mean, this doesn't so much fun for the floor, but in terms of giving vasopressors, you can give a vasopressor through a peripheral vein for at least 6 hours. Some people will say even 12 hours if it's low concentration. The minute you start higher concentrations, then you need central access. Okay. So I want you, as far as the identification of sepsis, you need to make sure and ensure that you understand who is at risk. Are there risk models in place in the ward when a patient is admitted to say this is a person that is possibly high risk for developing septicemia, if not now, in the future?
I know in Emerge they have the first net flag, and then they usually pass it on to us, but we don't have anything that would be a trigger.
Nanaimo with iHealth has a sepsis trigger that
Oh, okay.
flags, and then it'll follow them for quite a while.
Yeah, so what I'm trying to say is that the sepsis triggers, or the screening tools that they use, the Quick Sofa is the most bedside friendly one, but there are several others. There's SIRS, there are the Muse, there's Pews, there's a whole bunch of them, but they look at a whole rigmarole. They look at platelet count, they look at lactate, they look at white cell count, they look at a whole bunch of parameters that may or may not be available in order to calculate it.
Yeah.
I'm talking about purely profiling the patient to say, look, this is old Betty, she's come in because she's had a fall, she's broken a mechanical fall, she's broken a hip, but she noticed that she's been in hospital 30 days, within the last 30 days or the last 60 days she's been in hospital. We need to put a flag on her to say we need to watch out that sepsis may arise in these patients. Now, in terms of just as an add-on, at the moment is that there's a lot of interest looking into vitamin C and its use in sepsis. So those are studies that are going on because they know that vitamin C is used in the manufacturing of norepinephrine. It's an antioxidant. It has strong and significant immune implications. So, and what they find is people with sepsis, their vitamin C levels go to nothing. So now they're looking. There are some small studies that have come out to say that there is actual benefit for high dose vitamin C. What would be interesting in our context is to say that if we are going to do an audit to work out how many sepsis we're getting from the floor versus from emerge. If we do we're going to do a study where we're going to look at people's vitamin C levels on the floor, and we're going to supplement them orally with high dose vitamin C as inpatients, and we're going to look at the incidence of sepsis or poorly prognostic sepsis on the floor. Okay, so this is coming in terms of the use of vitamin C in sepsis. Okay. With regards to sepsis, I just want to touch on one form of sepsis, pneumosepsis. Pneumosepsis is basically a pneumonia and where the patient becomes septic. Fluid balance is extremely important in these patients. Extremely important. You don't want to overload any patient, but in particular your people with pneumonias and sepsis. Fluid should be limited to approximately 2 liters at a most. I do not want to hear if the guys you give 2 liters, and if they don't respond to 2 liters, that's where fluid resuscitation stops, vasopressors are started. Okay, and then of course there's an assessment by a physician. So I don't want any nurses giving like 5 liters of fluid because the doc's saying, no, give another liter, give another liter, give another liter, give another liter, give another liter. You follow. 2 liters. Give 2 liters in, and then you should start to consider that you need to start vasopressors early. Okay?
Yeah.
I mean, of course, this is not a fixed rule. You then need to be assessed by the doc, but I don't want to, over the phone, just give another read and call me back. You give 2 liters of Ringer's lactate, and then you see where you're standing.
Why sepsis and pneumonia? Like, why is it? What is it about the lungs that?
Okay, so the thing is, if you know, and you've seen it lots of times, that these guys get lots of fluid, and then they start to balloon like a Michelin man.
Yeah.
In third space, they get edema everywhere because they're getting a capillary leak.
Okay.
Okay.
Yeah.
So what essentially is happening there is that it happens in the lungs too. So you have damage to that alveolar, arterial, capillary interface, and because you have that disruption because of inflammation, it's leaky, so that you can fill that component of the lung with fluid, and then it overflows into sort of a normal aerating lung. And what you end up there is you end up getting intubated, not because of the pneumonia, is because you've absolutely got fluid overloaded there. So you want to run them a little on the dry side, especially for your pneumosepsis. Okay. Mr. Renault on the floor, being on the floor. Yeah. Do you guys know him? Did you know Mr. Renault?
No.
Yeah, he's a case in point where thoracic trauma, pneumonia, any sort of contusion or bruising to the chest wall of the lung, you need again run and dry. You know, fluid overload, and we've had this discussion before in previous episode. Fluid overload is a big killer on the floor. Okay, so weight monitoring, fluid balance is extremely important. I can't tell you how important making sure that people are euvolemic, if not a little bit on the dry side of this. Whacking people with fluids is bad news. You know, and particularly in the realm of sepsis. The whole Rivers trial, which you may or may not be aware of, where they did directed sort of targeted therapy, where they would target certain hematocrits, certain hemoglobins, certain venous gases and all the rest of it, that's now found it to be out of favor, that it's actually on the basis of your assessment of the patient. Okay. Are there any questions? So I just want to know from the nurse, from the guys, last time we did assessment or respiratory assessment. We need to, neurological assessments, has that been touched on? Has there been a wish list in terms of what topics you want to get covered? Is there anything?
Can I say something, Mark?
Yeah.
Actually, in terms of the identification of the patient that is septic and the institution of effective therapy, how quickly are we wanting to start antibiotics?
I would tell you, like, immediately. I would tell you, if you can get blood cultures done, you see the patient, it's triggered the protocol, you get the blood cultures done, and then you give it straight away.
Yeah.
One of my biggest bugbears, especially in the emergency department, someone that's looking like they're septic, it takes hours before they get given their antibiotics.
Because they're waiting on blood cultures.
Or because you're waiting on the lab to do it.
Yeah.
So that little step needs to be addressed. So I don't think if you guys trigger it, you say this is, how long does it take the lab to come do blood cultures?
Well, I
Depends
don't
what
know.
time of the day it is too.
Well, we know that, okay, so we know that.
Not
a lot of-
immediately. That's for sure.
Yeah.
Like, even if it's stat, I've had one stat and they probably took 10 minutes and they're literally just right there,
Yeah.
right?
So, I mean, the sooner the better. I mean, if you're waiting half an hour, I'll tell you that's 10 minutes, I think is reasonable.
Okay.
But I mean, you must be sitting with the flip tasks
Right.
like all lined up and ready to go and say, okay, get these blood cultures down
Are
now.
you waiting, like, if you've got the blood culture and you strongly suspect someone's septic, is there any harm in hanging the pep test and getting it going? In anticipation that the blood culture results are gonna be?
Or are you waiting
saying,
for the
are you
results?
saying
You-
wait
you-
for
the
the, are you
reasoning
saying
being
wait
is
for the
it-
results?
hmm?
Or are you saying wait for the results?
No, I'm saying getting the blood culture drawn.
Drawn,
You don't want the
Yes.
result, you want it drawn.
Yeah,
Yeah.
yeah, but then hang that sign.
Yeah, and hang it and run it in.
Yeah.
I mean, the issue why I don't want it the other way is you don't want false negative blood cultures. Because depending whatever we isolate, it will determine we can rationalize our treatment and we can adjust accordingly. Okay, so I would tell you that there needs to be a deadline on the floor at night. How long does it take them to come and do the blood culture, say 2 a.m. in the morning?
Well, they have to come in,
Yeah,
right?
I mean, they should be here, what, within 20 minutes? I
Yeah.
would say at the
20
latest. I
minutes,
mean,
half
I
an hour.
haven't worked in Emerge, right? And I think that is the challenge too, right? Is it's a common argument in Emerge, right? Is, okay, patient's septic, we were hitting all the numbers here that say the patient's septic, and we're still waiting on cultures because we can't get the access. We've got an ID in, we're giving fluid, we need to give the antibiotics. Yet there is that dance around. Well, we need the culture first. I want the culture first.
Yeah,
before we
so
get the antibiotics, right?
what we will basically say is that we know that early administration of antibiotics changes outcome. So I would tell you that a reasonable time frame has to be agreed upon in this hospital. To say that if we cannot get blood cultures drawn within 15 minutes of us requesting it, that we're going to just give the antibiotic, and the blood culture can happen anyway after the fact.
Delaney, can you come here?
Yeah.
Okay, so I don't know who we need to speak to adjust those parameters. But if you're telling me they have to drive in to do blood cultures, that's not good enough.
Is the lab not here through the night?
Nope, they go home at 11:30 at night, or 12.
Yeah.
I'm not either.
I mean, they're pretty quick about coming back, you know, when we call them for Emerge, but
Yeah.
still.
But it depends where they live.
A nurse is not allowed to take blood.
Not-
Through a pick, I guess, right? But that's
Yeah.
That's a little
They
different.
don't
You
do
can't
it.
do for blood
No.
cultures.
Yeah, you're on the floor now.
No. I think the direction, my understanding of it, right, is that the lab has to be there. So even if we pull off a pick, the lab has to witness us
Doing that.
pull the blood off the pick.
Okay, so it's
You know,
not-
in a trauma Emerge, that might change, but for the most part, we're pretty. It's not something that would happen on the floor, I can tell you that. Try and-
Yeah, so then the issue here is that, you know, the antibiotic get given anyway, and screw the blood cultures. You know, I suppose there are other ways we can check for certain organisms looking at urinary antigens, which is something we could possibly do. But sensitivities and stuff like that, you need an active growing culture. Okay, so in summary, I just want to stress that you need to ensure who those high-risk patients are, bearing in mind that people that have been readmitted recently, they're high risk right off the bat, and be aware of medications that are blurring your clinical presentation, the use of non-steroidals, acetaminophen, diabetics, they're not going to present in the same way. I would tell you altered confusion is sepsis until proven otherwise in an elderly group. Okay, and that's the take-home message. Don't wait for the model, because we're in deep trouble with that. Okay. One of the sensitive signs is also the spreading of the diastolic and systolic blood pressures. That will be one of the more sensitive pickups to say, yeah, they're starting to widen. And that's a very bad sign.
Any other considerations for like the immediate post-op period or even intra-op? Because that's who we're going to see, like in recovery from anything.
Your Zaid specials. Yeah, the urology patients going septic. Yeah, so there's something to be said about what they're actually giving them preoperatively. I understand they're getting pre-medded, they're getting cefuroxime.
500.
We give Cipro-PO.
Cipro and Tylenol.
Tylenol. Cipro-Tylenol. That's the standard.
And
Tylenol,
you-
1 gram.
and maybe some
Cipro.
ANSEP interoperative, like
Yeah, and
patient.
ANSEP control.
Yeah, so I would say that they should, well, see, Ansef is cefuroxime, so it's a second generation cephalosporin. It intrinsically has very bad gram-negative coverage. A little, but it's predominantly gram-positive, and you're dealing with gram-negatives. So I would say that in that instance, we would probably give them 1 gram of ceftriaxone intraoperatively and see if that has had any impact. In the PAR, or your post-surgery in those patients, it's pretty fulminant in terms of the onset of sepsis. In your on the floor, it can be quite grumbling, like it kind of sort of it's several hours will pass before you go into full-blown. Where in the PAR, because of the nature of the procedures done, sepsis can come knocking really, really quickly. Especially when they go and put in stents to get a transient, a massive bacteremia from just the pressure working in the ureters, etc. And then it gets. So I would say, given the incidence of post-operative sepsis that we've had, particularly in a urological, I would say that the intraoperative antibiotic should change to ceftriaxone. If we're talking about penetration, ciprofloxacin, IV. IV or oral, but I would say, it would be interesting to say, well, why don't you have 500 milligrams the day before, or 2 days, 1 dose there, 1 dose, so 2 doses the day before, a dose when they arrive, and then do like a 5 days of Cipro and see if that actually has any impact on, because cefuroxime is just not good enough.
Well,
There you go.
Okay.
okay,
Okay. That's something that needs to change.
yeah.
Because we've had, internal medicine's had several of those guys.
Because I know we tend to, see a lot of ceftriaxone with.
There should be a conversation.
Yeah. Yeah, we've had few. More than you would like to sort of.
Because that's our orders. Those are on our standing orders.
For the urology patients. Yeah, no, it needs to be adjusted. This gets made to adjust it. And there's no antibiotic stewardship at this hospital, I think.
Well, what was the pharmacist's name? Mark. He, I know I've seen a couple of chart notes from him and Rich as well.
So what happens is the laboratory pulls all the cultures that we've grown retrospectively for the last year, and it looks at the sensitivity. So we've got like E. coli's they're usually this sensitive,
In this town,
in terms of what are we seeing here? What's our incidence of VRE? MRSA, ESBL. How many are we getting? Okay.
I've gotten the phone. I know we've had taken phone calls from Victoria too, from microbiologists, wanting to talk about medications patients are on. I've had those phone calls.
But remember your uro cefuroxime,
Okay.
not appropriate.
Okay.
Okay.
Thanks.
Thank you.
Great.